I can't see him here, but I'm sure he will be joining soon. And the second case is also a medical case, and Dr. Nitu Mundhra will be commenting on that. These are two very lovely medical cases. And finally, we have so many, standard treatment guidelines being published by the Central IIP. Dr. Anuradha Palwankar will be presenting one of that. So to begin with, we are going to begin with the epidemiology because that's what's the, rather the trending thing. So first we begin with Dr. Smita Chavan. And Dr. Smita Chavan is a big name in the COVID management. She was head of the COVID task force, as well as she led the Seven Hills and the Municipal Corporation of Greater Mumbai. Today she's going to give us an overview of COVID, its resurgence in the VCMC area, in Maharashtra, in India, in China especially, and the world over. So over to you, Dr. Smita. Please unmute and start your deliberation.
Thank you so much, ma'am, for a nice introduction of mine. And respected seniors, dignitaries, and all colleagues here, and pediatricians over here. Good afternoon, everyone. I, Dr. Smita Chavan, I'm currently at the Cooper Medical College as Associate Professor in Community Medicine, and also I'm Nodal Officer for COVID here in this hospital. And I worked at Seven Hills Hospital as Additional Dean also. I can see many familiar faces here, Kishore, Chavan sir, and
yes,
all the seniors here. I'm very happy that something the IIP is doing for this impending pandemic. I won't say that basically, but still looking at the scenario worldwide, and then media have all going on, and related to the COVID's do's and don'ts, and where to, we should lead ahead with what things and all. Everybody is worried with this. Each variant, each type of this COVID had different presentation altogether, and we really can't predict now this variant how the things will go with us. But hopefully after Delta variant, we haven't seen much malignant variant of COVID virus after the Delta variant. Omicron, UK variant, many other strains had come, substrains, subtypes, but yes, Delta was the most malignant variant we could face in the COVID pandemic. And now the recent variant, which all of them are talking about, BF.7, that is also the subvariant of the Omicron virus. But let's see, the time only will tell us regarding the behavior of this virus. And then again, there are many things which was there from the day one of the COVID until it is same, that comorbidities and the age factor. So it will also be there now also. So the risk is not less. We all think that yes, now nothing will happen, and then we can't predict for the old age and comorbid patients with us, and also the pediatric patients. We are not very sure about this, the complications, long-term complications. Still, there are many papers now, they are getting published for the long-term COVID, post-COVID syndromes and all. So we may or may not get the active cases, or maybe the very critical cases with this virus, but we do not know the long-term effects of these virus. So why to expose ourselves, and why the community will expose themselves for this virus? It's better to prevent this infection. And we always, a community medicine people, we always say that prevention is always better. So preventive things are the, again, same, masking, social distancing, and in crowded places, and then get-togethers and social gatherings, we need to have some precautionary measures right from our side, healthcare workers. We should start with us. I travel daily in train, and then I have started using mask. So we should take precautions ourselves. And further, now everybody is talking about the 4 booster dose also, and vaccination. Those who are not taken precautionary doses, that dose should be taken. 4 dose, we are not sure. IMA had given application for the government of India for the 4 doses for healthcare workers, but no such circular is come to us. And again, the variant is different. And we have with us in municipal corporation only Covaxin available with us. And Covaxin we are giving as booster dose to the Covaxin and Corbevax also. But now the circular is also come for the nasal vaccine. The details have come, but then no such official circular is there to implement. So we have not yet implemented the nasal vaccine yet. That is Bharat Biotech product. So as of now, the situation globally, what we can say till date, we had more than 65 crores of cases. And death, if we say 6.6 crore of means 10% or so deaths. And if we see that within the last 24 hours, how many cases globally, so then it is like 7.7 lakhs cases in the last 24 hours, we can say. But about China, the numbers, I'm not very confident. Till date, China has got 10 crores or more cases and deaths, not very sure, 31,000, but it's, that number is, I can't believe, I don't know. So 31,000 is very less. And then in last 24 hours, they have 28,000 cases itself. So I am not very sure about the China, the numbers. And then for India, I can say that till date, we have 4.4 crore cases. Out of that, 5.3 lakhs deaths. And in last 24 hours, we have 163 cases. Out of that, Maharashtra is having, I mean, on an average, 25 cases on an average in last few days. And in Mumbai, we are having up to 10 cases per day, 6, 7, 8 cases per day. So looking at this scenario, as epidemiologist, Kishore sir also will agree with me that we have to watch on the trend. And as of now, this thing is not out of hand, or it doesn't look like that it will be very soon. I mean, we'll have to face a big thing now. But still, the preventive measures are very, very important for us. And then we have, as a Mumbai, I mean, MCGM is at the forefront, whether for the screening or quarantine or everything. So the number might increase because we have increased the testing. When you increase the testing, automatically you get the positive cases. And then when the number rises, then media again makes a havoc. But then we need to see people who are old age, who are comorbid, how they are getting affected and how they are, I mean, what are the seriousness in such cases. Otherwise, it can be the mild flu-like syndrome, like flu-like infection, and then upper respiratory tract infection. But yes, we have to prevent that infection in the community. Mask is very important again, and social distancing. And we need to be very cautious about the children also. Now the circular is come for school children for masking in the school, compulsory masking and hygienic practices that is there. That's what I can say, ma'am, as of now. But we are there to keep watch on this virus, and we are there to help you out all the time. Thank you, sir.
Thank you so much, Smita. Thank you for that. I hope this is not just the calm before the storm, because I'm sure in 2020, the same thing had happened. We all thought that's only a Chinese disease and it's not going to come here. And then all of a sudden in March, all hell broke loose. So I hope it's not anything like that. And please take
yes,
care.
ma'am, that is the reason we yesterday and day before we did the mock drill. As a nodal officer in Cooper Hospital also, we did mock drill. Nationwide mock drill is done in that infrastructure, human resources, instruments, equipments, readiness for the training, and everything was assessed. Lacunae were detected, and then we tried to fulfill the gaps. If at all we need to go ahead with this serious thing, then we should be ready to face that situation, and we can prevent the serious means. I mean, we can prevent the disaster further. Thank you, ma'am. Thank you.
Thank you so much, Smita. Thank you for that input. And if the intranasal vaccine is coming anytime soon, do let us know so that we can send out a circular to all our, and I hope it comes in the private domain, because the vaccines to procure it in the injectable state was very difficult earlier.
This Covishield is not available. They are available in only 2-3 private centers. Government, we do not have Covishield. We have Covaxin only. But I am a phone call away for you all to know the situation for vaccination also, ma'am.
Thank you so much. So please do let us know when the 4th booster is coming, and I'm eager to take that. And if the intranasal come, I would happily take the intranasal. So thank you very much for that, Smita.
I have a meeting now, so I would like to leave also. Thank you so much for this opportunity to interact with you all. Thank you so much.
Thank you, Smita. Thank you very much. And Dr. Kishore, do you have anything to add on the?
Yes, madam. Smita has almost covered everything. I just wanted to highlight on 2-3 slides of China, so that we'll try to learn something from that. Shall I share my presentation, madam?
Please do that. Please do that.
Yeah. I have 3-4 topics, but just 2 minutes each.
Yeah.
I'll first finish this measles, madam.
Yeah.
Okay. There's a large measles outbreak in India this year. You can see the first map at the base of the first map. This 2020, 5,500 cases, 2021, 5,900 cases, and to the 2022, we have got 18,000 cases. So this time the cases have increased almost 4-fold. Even the rubella cases have increased marginally. And if you look at the globally, you can see the cases are more in African countries and Southeast Asian countries. In Maharashtra, we had 1,400 fever thrush cases, and lab confirmed were 1,100, and confirmed measles death are 23 as of today. 23 measles death in Maharashtra.
Fever rash for 14,000, not 1,400.
14,000, sorry, 14,000 fever rash cases and 1,100 confirmed lab confirmed cases. If you look at the Vasai Virar data, madam, here we had suspected 819 cases, samples collected 297, deaths positive cases were 42 in Vasai Virar. Deaths 2 cases, that is in Palghar UPSC. There are total 18 outbreaks this year. Out of them, 15 are still active, 2 outbreaks have become inactive, and 7 positive outbreaks are right now. Positive outbreaks are going on, and these positive outbreaks are 1 in Palghar, 1 in Patankar Park, 1 in Dhanu, 1 in Valyu, 1 in Jalawad, 1 in Ambedkar Nagar, and 7th is in Bodins. These are the areas where the positive outbreaks are still going on. The following data is little interesting. You can see the MR1 vaccinated. You can see MR due cases where 20,000 children were still due for MR1 vaccine. This was done after this survey. When survey was done in 4,31,000 houses, we found that 26,000 children were not having even the first dose of the MR1. So you can imagine how many children were left behind, and that is the real reason why the outbreak was going on in Vasai Virar. So out of them 26,000 cases, children, 17,000 were immunized with MR1. That comes to 67%. It means still 33% children are still not immunized with the MR1 vaccine. And I'm sure that all those will definitely get infected with the outbreak going on in VVCMC. MR2 due children were found again 26,000. And out of them, 16,000 were vaccinated, and the MR2 vaccinated was 63%. So still 33% were children are not having the second dose. So you can imagine the resistance from the community, certain communities regarding the vaccination. The corporation have identified all these children, but many people are there still not taking the vaccine. Just a minute. Madam, can you hear me? Hello?
Yes, sir, we can hear you. Yeah.
Yeah. Now the second topic is IPv3. IPv3 has been introduced in India. It will be introduced from 1st January 2023. India is polio free since last 11 years, but risk of importation of wild poliovirus and vaccine-derived poliomyelitis is still there. That is especially type 2. This map is very important. We still have wild virus cases in Pakistan, Afghanistan, and some cases in Mozambique, that is near South Africa. And these green dots are the VDPV2 cases. When we switched to BioPV in 2016, that time this VDPV2 were 0. And then we shifted safely to BioPV. But after 2017, this VDPV2 started circulating, and we are getting so many cases now. You can see that there are almost 300, 400 cases of the VDPV2. Initially, we have started with BioPV, and we have started giving the IPV 2 doses, one at 1.5 months, that is 6 weeks and 14 weeks. Now let's see what is the immunogenicity of this particular schedule. When you give full dose of IPV at 6 weeks and 14 weeks, we get around 80% immunity. And if you give full dose at 14 weeks and 9 months, that is 3.5 months to 9 months, 2 doses, then we get 100% immunity. And I think IAP schedule fulfills this particular for 100% immunity. India has started giving the fractional dose IPV, 2 doses, one at 6 weeks and second at 14 weeks. And that gives only 80% of the immunity, 17, that is 80% immunity. This 80% immunity was good enough for us to stop any transmission, because that time the type 2 virus was not there anywhere. In 2016, the wild virus type 2 was not there, and even VDP type 2 also was not there at that time. So initially this schedule was good enough for us. But looking at the VDPV2 cases in the African countries, now there are very high chances this virus might get imported to India, and it can still spread here, because even if you give an IPV to 100% children, the 20% will be still unimmunized or without immunity or without protection. So now there is a high risk of getting the virus in India and getting circulated here, especially the VDPV2. So now the government of India has decided to give third dose of IPV at the age of 9 months. So we will be giving the dose at 6 weeks, 14 weeks, and 36, that is 9 months, along with the PCV and MR1. So this will give almost 100% immunity. So from this we are starting this FIPV3 from 1st January 2023. And there will be slightly different. I mean, this is not concerned with us because it is the government sector area. We give FIPV1 and 2 on the right arm, but FIPV3 we will be giving on the left arm. The guideline has been circulated, and all the vaccinators have been trained accordingly. Okay, this was about the FIPV3. COVID.
Yeah, Smita, but will that not interfere with the BCG side on the left?
No, madam. BCG is very much upper side. It's on the deltoid.
Okay.
It's on the deltoid, and any 2 injections they can be given 1 inch apart.
Okay.
Yeah, even if you have to give 2 injections, they can be given on the same side, 1 inch apart. They can be given.
Okay.
And the BCG has been given long back, and so we are giving in this biceps muscle, right?
Okay.
Sorry, triceps muscle.
You mean in the deltoid you are going to give intradermal or triceps?
No, we are giving on the left side. It will be at least 1 inch apart from this particular scar.
Behind.
BCG scar.
Okay.
No, lower side of the BCG scar.
That will be in the deltoid only, because the deltoid is so big, no?
Yeah. But the guideline is that only one inch difference should be there between the 2 injections or the scar. Yeah.
Okay.
Yes. Regarding this, Smita has already covered, but this is something about China. What people, WHO perceives, right? The number of severe cases and hospitalizations have reported in mainland China since mid-November. Available information suggests growing demand on healthcare system, with several reports of significant pressure on healthcare system. As Dr. Smita said, we really do not know what is happening there. There might be many more cases there, but the data is not coming out. But whatever the indirect evidences we have, the WHO has it, they have drawn some conclusion out of it. The second point is, however, the daily number of reported infections are decreasing in mainland China, with some 2,650 daily cases, new cases reported as on 21st December. The reduction is due to reduced testing and new policy not to include asymptomatic infection in the case count, among the other factors. These are the reasons why the number of cases are coming less in China because their testing facility, this thing strategy changed. China only counts death from respiratory failure as COVID-19 related deaths, resulting in very few deaths being reported and making it difficult to understand actual disease burden. I mean, here what in India, if suppose someone dies and if he's COVID positive, then we label it as a COVID positive death. But they have strictly put it into that a respiratory failure. That is a condition. That's why the number of deaths will be always shown less by the China. This is the China mainland, where the large number of cases are there. What is the implication on us about this China epidemic? COVID-19 cases amongst travelers from China may increase, and its impact depend on the movement of the people between China and respective countries and countries' health system capacities. Given that the variant reportedly being circulated in China at present are now new to Southeast Asia region, the impact of the potential importation of cases from China could be limited for most countries. Considering the level of population immunity in countries, adjustment of the international travel measures should be risk-based and informed by thorough risk assessment. However, the impact on Korea is uncertain, given very limited population immunity and its geographical proximity and close relationship with China. The continued high level of transmission in China may lead to the emergence of new SARS-CoV-2 variant. All countries should be vigilant and maintain readiness for possible future surges. This includes sustaining efforts for testing and genomic sequencing to ensure the adequate monitoring and early warning. All countries are also encouraged to continue their efforts to ensure high vaccination coverage, especially among the older adults and other high-risk population, including booster doses. This is about what government is doing. This is just one example. Smita has already explained about it. I mean, they are doing a lot of preparations at all levels, at the district level, in the corporation level. There are a lot of preparations are being done. Lastly, with the monkeypox, what is happening? The total number of monkeypox cases in the world till today is 83,000 and 72 deaths. And these cases occurred in 110 countries up till now. Since January 2022, cases reported WHO 110 countries, 6 WHO regions, 83,000 cases, 72 deaths, and mainly in 2 regions. One is European region, and second is region with Americas. You can see the graph on the right side. Currently, 70 out of 110 countries which were reporting the cases, now they are not showing any new cases. Out of 110 countries, 70 cases are not countries are not showing any cases now. India had 2 cases, 15 in Delhi and 5 in Kerala, and we didn't have cases in our state. Expectation from participants regarding the measles outbreak. Thank you very much for reporting many measles fever rash cases. So identifying and reporting any suspected measles cases with a fever rash, maculopapular rash. Verifying vaccination status of children more than 9 months for more MR containing vaccines. Participation in task force meeting at state, district or block level. Motivating parents to timely vaccinate their children. Support in public health response activities of measles outbreak. And finally, request to report all the AFP cases below 15 years of age, fever with rash cases, suspected diphtheria, suspected pertussis, neonatal tetanus, and AEFI cases. Thank you very much, madam.
What about mumps? We are seeing a lot of mumps also now.
Yes, madam. There is no protocol for mumps cases because Government of India, from the public health point of view, mumps is not a fatal disease. It doesn't give very severe complications like other diseases like measles. So Government of India doesn't perceive it as a public health problem at this moment because Government of India has other priority diseases like measles, rubella. These need to be eradicated first, eliminated first. They might take mumps after some time. They might include that mumps vaccine in the MR vaccine later on. But as of today, they still have other priority problems to tackle.
Okay. Because mumps is on the rise, and at least in the last week, I have seen 2 or 3 cases.
Yes, ma'am.
I think Dr. Mahesh Mete also said that he saw 4 cases of mumps. So I'm sure there must be many more than is being seen.
Yes, ma'am.
We appreciate your work, and Dr. Kishore Chavan is a very senior WHO consultant, and he has been with us for last, I think, 5 to 7 years.
Yes, madam. 7 years.
7 years. and very, very vigilant, and we have a common group, and we always report cases, and there is real-time recognition of everything. So,
yes, thank you, ma'am. Thank you very much for the reporting cases.
yeah, and he's very quick on the uptake, and action taken is very swift. So thank you for all of that, Kishore, and we'll be on a lookout for fever with rash, for AFP, for monkeypox. We have fortunately not seen any monkeypox. I think there was one case which Dr. Jagdish Bhadbade wanted to work up, and I don't think it turned out to be monkeypox.
Yes. Madam, we tried to send the sample of that patient, but patient refused to give the sample. We tried to persuade the patient, but they were not ready for the sample, so we could not.
Yeah, and of course we'll be on the lookout for COVID cases. So everyone do take COVID may be on the rise and it's on the horizon. So SMS like before, that is sanitization, masking, and safe distance. So take care, everyone, about these infectious diseases. Thank you so much, Dr. Kishore. And we'll see you again next month. And we hope that you attend all our epidemiology talks on our monthly CMEs. Dr. Kishore was not to be present today, but thank you so much for coming, because he had another very important meeting, and I said, no, you have to come here. I pestered him in the night, and he's here. So thank you for that.
Thank you, ma'am. Thank you.
Thank you.
Thank you, sir.
And with that, we go on to our cases. Today we have two very, very enthusiastic presenters. And I will first request Dr. Kant Shah to present his cases. He is going to present some lovely surgical cases. And Kant, over to you.
Thank you, ma'am. Thank you very much. I hope you can all see my screen now.
Yes, sir.
Yes, we can see.
Make it full screen.
Yeah, just one second.
Yes, sir, it is full screen. Yeah.
Okay. I'm just trying to get everything aside. It's just coming in my way. Okay.
Yeah, sorry. I didn't introduce Dr. Kant Shah. Dr. Kant Shah is, as all of us who attend these monthly meetings, when we used to have physical meetings at Dr. Joshi's place, he was always there, and he was always presenting cases, always commenting on our patients. And today he is presenting online, and this is not the first time. He's always been with us. He is a consultant pediatric surgeon, especially interested in oncology, and also in urology. He runs a very good clinic at Borivali, which deals with urodynamics. And he's also a consultant at Dandawate, Jaslok, and I believe he's also at the Thalassemia and Oncology Center at Borivali, at Kandivali.
Not anymore, madam. Not anymore.
Okay. Yeah. So he used to be attached over there, but now.
For three to 3.5 years, not anymore.
Okay. Okay. So he's a consultant at Nanavati and Jaslok. Yeah, come ahead. Go ahead.
Thank you. Thank you for the generous invitation and introduction, madam. It's always a pleasure to talk to this very enthusiastic group of physicians. And I think we have a record 33 people today. So thank you all for coming. I will not waste too much time. So I've got actually little more than 2 cases, madam, but I'll try and hurry up so that it's not wasting too much of your time. So the first case is a 4-week-old baby. It's a female baby who presented with non-bilious vomiting for 3 to 4 days. And the vomiting was progressively worsening, and there was history of constipation. If you ask the parents, especially the mother and the grandmother, they said that the vomits are getting bigger and bigger, and the child is vomiting almost every feed now. So I'm sure, being a surgical meeting, you've probably guessed what this is, but can I still have some responses?
What about hypertrophic pyloric stenosis?
Yes.
Yeah.
It's a female that's against it, but the age and the kind of vomiting is like a pyloric stenosis.
Thank you for highlighting both these points. So the femaleness is actually not against it. It's just that it's little commoner in males. So we always think that female mein nahi hota hai, but no, we do see a fair number of female babies also with this. And secondly, madam said that age. So age is very important here. The outer limit of pyloric stenosis is 2 weeks to 7 weeks. The commonest you see is 3 to 6 weeks. So this is bang in the middle, and then this child fits with that. Also, what we see frequently with a pyloric stenosis, the vomiting will get progressively worse. Today's day and age, you may not see projectile vomiting. Projectile vomiting we used to see even in UK. I've seen where the child has become very cachectic. It's hungry, it feeds, it rests, and then suddenly has a very large vomit. So this is a child who's getting tired and fatigued. That usually happens after 7-10 days of such severe vomiting, where they've pretty much thrown out everything. And I've seen even sodiums like really in the boots and all, but that doesn't happen nowadays. So nowadays the picture has become more difficult because all of you are picking up children earlier, and then we have to be very careful of whom to investigate, when to investigate. So again, history comes into play. Progressively worsening vomit, it should be almost every feed. In fact, by the time the child gets operated, it should be every feed. If it's not every feed, then it may not be pyloric stenosis. That is one thing we have to remember. It should be almost the entire feed, or it should be the entire feed. It should not be small vomits. It's very unlikely that it is pyloric stenosis. It's only small vomits. It may start as small, but it does progress, and by the time it is significant, for you to label it as pyloric stenosis, usually the vomiting is almost all the feeds, almost the entire volume, and it will at least take 4-5 days or 6 days to progress to that level. And apart from, so constipation is a very subtle marker. Most of the babies with the biggest differential here is GER. So most of the babies with GER will not have constipation. They'll be thriving, growing, but also have GER.
Is non-bilious also a very important?
Absolutely. I mean, non-bilious means it has to be before where the bile ducts join. So without question, it has to be always non-bilious. And sometimes we do get children who come with dehydration and decreased urine output also. So that's also very important. So the test that we would all do, I think everybody does, is ultrasound. So there are certain criteria for ultrasound. So the length in this child was 18 millimeters, which fits the criteria, and thickness was 4 millimeters. But what I do always like to do is make the baby very quiet, either by giving a test feed or just putting on the mummy's lap, and try and feel the mass. It's extremely rare that we have not felt the mass and operated, because ultrasound, it's very user dependent. Where to measure the pylorus, we're talking about millimeters. 18, if it's 14 millimeters, you are very borderline. 4 millimeters thickness becomes 3 millimeters, you're very borderline. So we have to be very careful. So that's why I always like to palpate the mass before I operate. This child needs to be admitted immediately. I do see a fair number of patients where they take a day or two to decide, and that child can get very dehydrated in that time. So you have to make the parents understand that this child cannot tolerate any fluid. There is no point trying something at home. It's not going to tolerate anything. So IV fluids are must. An ABG is must. This child had a pH of 7.45, sodium of 135, chloride was pretty much okay, potassium was okay. So the fluid of choice is always 0.45 DNS, never any other fluid, unless you want to make it full DNS, which is a little rarer. But if the sodium is very low, then you will make it full DNS. Otherwise, you will give half strength DNS plus minus KCl, depending on what the KCl is. Almost nothing in pediatric surgery is an emergency except for like bronchial foreign bodies, and so never rush in surgery. I would always like to stabilize this child, give IV fluids for good 24-48 hours, and then only operate this child. Nowadays, we are doing this umbilical sort of pyloromyotomy. So if you can see that the top left hand corner is where the pylorus lies, and usually the incision used to be over there. In that skin crease you see, it used to be a much bigger incision, and that incision doesn't heal very nicely. It looks fairly like you had a very major surgery. It almost looks like a proper laparotomy when the child is older. So many years back we learned this umbilical incision, and it works really well. The scar is pretty much hidden. You will not realize this child has had surgery also, and that obviates the need for doing any laparoscopy, etc. Just how the pylorus looks like. So once you've pulled the stomach out, I'm sorry, this photo is upside down. The legs are here. So just because you can see easily. So you see the stomach is very supple and the pylorus looking very thickened and hard. The pylorus should have also been supple like this. So this is how the pyloric tumor, pyloric mass or IHPS looks like. And the surgery that we do is we cut open the muscle and leave the mucosa inside. So you can see now you have split the muscle completely and you almost get like 2 halves of the muscle, which we check by movement independently. And as long as the mucosa is intact, that is the end of surgery. And if you have adequately resuscitated the patients before surgery, then you can start after surgery the feeds very quickly. This child, we started on 6 hours after surgery, we started feeds, and by 2 days, this child was home. So the pre-operative resuscitation is far more important so that you don't struggle with the post-operative cause. Otherwise, this child will keep on vomiting a little bit because their metabolism is still not completely settled down. So that's IHPS. This is the second case is of a 3.3 kilo baby who was presented at 3 months of age to the pediatric surgeon. He was ex-34 weeker. He was gaining a reasonable amount of weight, not huge. I can't remember the birth weight, I think it was 1.7 kilos. And the child had recurrent intermittent non-bilious vomiting. Again, never bilious, it is always non-bilious. It is intermittent. It is sometimes small volume, sometimes large volume. It is very distressing at times. And it is twice it had happened that the child had choked after vomiting. Almost lost consciousness. So any guesses what this is?
GERD?
Yeah, so this is classic GERD, which is much more commoner in preterm babies. And it will always be intermittent. It will never be all the time. It will always be erratic, small volume, large volume. And sometimes to surgeons, when we get patients, we always get at this end of the spectrum and not the simpler ones. So a barium swallow and meal was done. It detected GR. The child was put on some anti-GR medications. They tried everything. The child continued to have really difficult episodes where it would almost choke. And then another milk scan was done. The child went to another doctor. The milk scan was done. That also showed severe GR. So then the pediatric surgeon called us and they said that it's a small baby, we would like a laparoscopic surgery. So I operated this child, we did a laparoscopic fundoplication. So this is the other end of the spectrum that you most of the time see. This is very rare that we need to do this, but we need to remember that acute life-threatening incidents, more than 2 is the cutoff. So 2 or more is a criteria for choosing surgery in children, where you have tried everything and everything has failed. The third case is a similar 3 kilo baby who got referred just last week, who was 2 months old, ex-36 weeker, had 2 episodes of choking following vomiting, very similar history. Grandmother had managed to do Heimlichs on the baby at home and resuscitate this baby. And they had tried lansoprazole and domperidone as well. The second episode of vomiting was not as, the choking was not as bad. And the parents felt that the baby was getting slightly better, but then this episode of choking happened. So they came to us. We did a barium and it definitely showed GER. On further probing, I realized that the parents seemed to think that the baby was slightly getting better and they were not very keen for surgery. What we advised them was that, look, you cannot take this child home because if the child chokes at home, you'll be in very bad trouble. If the only thing that you have not tried is feed thickening, because they had tried everything. They tried the position, lansoprazole, domperidone, everything. So a trial of Nestum rice with mozapride was given. And in-hospital observation is going on right now. The child is day 10, touch wood, has not had any choking episodes. Now it's day 10. So I have said that at least 2 weeks in hospital observation. And if the child is then fine, then they can be discharged. So this is another thing that can be done. If you look at evidence, I don't know if Lalita has joined, but if you look at evidence, evidence does not point towards thickened feeds. Evidence doesn't say that thickened feeds work very well. But I have tried it in many, many children. And even if you look at current guidelines, it is supposed to be given. The material of choice is some kind of a cereal. which is basically an inert material. In UK, we used to use pectin. Here, I have been using Nestum rice, and it works pretty well. It should not be something which will get absorbed very easily. So if you use like milk fortifiers or something, then that is not really thickening. It might get just absorbed. We want that substance to stay in the stomach for a long time and get absorbed very gradually. And in a 1 or 2 month old baby, Nestum rice will not get absorbed very easily. So you're actually using an inert substance for that baby and keeping it in a thickened material in the stomach for a longer time. That's the whole point of using Nestum rice. Or any other brand. I mean, I just know one brand, so I write Nestum rice, but it could be any rice cereal. I should write rice cereal and not Nestum rice. So the current management, as we all know, is proton pump inhibitors with prokinetics. We can add mozapride also. And reclining doesn't work very well, that is for sure, but it should be tried at least. And then thickened feeds with some sort of rice cereal is recommended. Just a quick word on fundoplication. So when do we do fundoplication? Fundoplication we do when we have life-threatening incidents, choking, aspiration incidents. And there are two clear, distinct category of children that we see as surgeons. One child is a child who's very preterm and has got severe reflux, or near term and severe reflux. They have a better chance of getting better over a period of time. Then the other group is the neurologically disabled children, where they are very unlikely to get better anytime soon. So these are the two different groups. Fundoplication works very well in the first group, where it's a permanent complete fix. The weight gain after that is pretty quick. And nowadays we're doing it by laparoscopy in the smallest of newborn babies also. We can always add a Mickey gastrostomy button if there is a very bad lag in weight gain. Then we can add that to enable quick weight gain also. The cons is that it may not work very well in children with neurodisabilities or storage disorders, trisomy, because if you see the picture here, in fundoplication, what we do is we wrap the stomach around the lower end of the esophagus. And we also plicate it to the diaphragm. Now, if you understand, children with neurodisabilities will have a very poor and weak diaphragm. So the diaphragmatic hole becomes bigger over a period of time. The fundoplication may migrate into the chest, or it may not work at all, especially with children with storage disorders, trisomies, etc. So here, we are forced to do fundoplication, but outcomes are a little less better. But they need fundoplication much earlier because they are not going to get better at all. So in counseling children with neurodisabilities or these disorders, we have to be careful that we have to tell them that it needs to be done, but the outcome is maybe 70 to 80% and not more than that, because there may be more problems in future. And they always, for such children, we always put a Mickey button because their swallows, etc., may also not be very well established.
What is a Mickey button?
A Mickey button is a gastrostomy button. Mickey is a brand name. If you had seen any children with a gastrostomy, nowadays we put buttons. A gastrostomy is a tube hanging out. We can even use a Foley's. The other end of a balloon is in the stomach and the other end is hanging out. Instead of that, now there is a cute little button available. The top of it looks like a shirt's button, little bigger. There is a small catheter and the inside is a balloon inside the stomach. So the child can even play sports, etc., everything. And there is just one button on the abdominal wall. Whenever the child has to be fed, a tube can be connected to it and feeds can be given. It can be disconnected. It's just a simple locking mechanism, connect, disconnect. And so that's called a Mickey button. So there's only one brand which is available in India, and that's the Mickey brand. So that's why I've written Mickey button. So instead of having a gastrostomy, then change it to a button. Nowadays with laparoscopy, we can just do a single shot button surgery instead of having 2 stages. But again, we reserve it for very, very children who cannot feed orally very well. We are very sure only in these children we do all these things. So that was about gastroesophageal reflux. I've got two more short cases.
Yeah.
Uh, yeah. So this one is a 6 days old baby. I don't know if Nitu's here. This is her patient who came to her with bilious vomiting. The ex, I think 32 weeker, whose birth weight was not 32, maybe 33 or 34 weeker, whose birth weight was 1.6 kilos. But by 6 days, the child had become very dehydrated, and the child came to her and the weight was 1.2 kilos. She resuscitated the baby. There was no sepsis as such. Child was obviously premature, and the child kept on having bilious aspirates. Initially, they were small volumes, but they increased gradually to very large volumes. So despite having an otherwise normal child who was just a little dehydrated, there was nothing else wrong with the child. And the child kept on having bilious vomiting. So finally, we decided to do an upper GI contrast study. And that upper GI contrast study showed a malrotation. So this child underwent a laparoscopic LADS procedure. So here I just want to highlight the difference that bilious versus non-bilious vomiting. There are 2-3 things here that we need to be careful. One is that this child, so presence of sepsis or not is very important. So you need a good neonatologist who can figure that out, the difference between the two. And sometimes even in prematurity, we can get occasional bilious vomiting. So those are the ones we usually wait. And Dr. Nitu did wait for this baby as well. But after a few days, we were not winning. The child kept on having bilious vomiting. And that is the time that we should do a contrast study. The study of preference is upper GI contrast study. We don't use barium anymore in small babies. The contrast study has to be done by somebody who's very well versed with what they're doing. But you can do it on in your own hospital also, as long as you know what you're doing. I'm just going to highlight that in a little bit while after this. So, next case is of a 15-year-old girl who came with pain in abdomen. The pain in abdomen was on and off for 10 months. It was colicky, intermittent. It was there every few days. And over a period of 10 months, the frequency of these pains had increased. The pain was very typical in the epigastric or the right upper quadrant of the abdomen. It used to happen about an hour or two after feeds. And the pain was such that eventually she has managed to reduce her diet to only small amounts of liquid diet. But anything else would just not, she felt that she was just not able to keep it and she would just keep on vomiting everything. The vomits were sometimes bilious, mostly all food. Sometimes they had some white. She had managed to lose weight from 75 kilos to 48 kilos over this 15-year-old girl, over this 10 months. So actually, when the first time I saw her, they said she has lost weight. I told them, you don't look like you have lost weight. But they said, no, she was very chubby to begin with. And they actually showed me photos for me to believe that she's actually lost from 75 kilos to 48 kilos. Because 48 kilos is not really bad at that age. So the ultrasound showed a normal gas pattern. So just can anyone want to comment on what this could be? Does anyone want to tell us what investigation you would do for this child and what the thought process is? So
you gave it away. You gave it away with your next slide.
I did, didn't I? Sorry.
Yeah, but ultrasound would tell us.
No, actually. So ultrasound is normal in this child.
Okay. Then a CT scan abdomen.
Yeah. So what are we thinking here from the symptomatology?
Somebody in the comment has said bulimia.
Very good. So bulimia is definitely something that we should all consider in adolescent children. Yeah.
Other thing is something like a intra-abdominal hernia.
I'll just answer that bulimia question.
Yeah.
I actually asked her, are you trying to lose weight? Are you trying to look, because she was chubby. So the first thought that came to my mind was that she's trying to lose weight, typical 15-year-old girl. So I put the parents aside and I asked her clearly, are you trying to lose weight? And she said, no. She said, I like the way I looked before. So when she said that she liked the way she looked before, then I realized that this is not a psychiatric illness, because then it would not be, because she was a very happy girl. She happens to be from a village near my village. And she's like, no, I really love eating and I just want to eat. So she's not somebody who's trying to lose weight, and she's not somebody who's a psychiatric illness. So I think that's a very, very relevant question, and it must be asked, and it was asked. Sorry, you were saying hernia.
Yeah, I said hernia or mental herniation of the stomach or something.
So an internal herniation,
Yeah.
is definitely a possibility here with an intestinal band, or a mesocolic hernia, which I think I presented long time back also.
Yeah.
Yeah, so that is definitely one. So some kind of a congenital anomaly you're thinking, which would cause an intermittent upper GI obstruction because there is no distension of abdomen. There is just epigastric pain with vomiting. Vomiting is so bad that she's not able to tolerate except for small amounts of liquid diet. She's able to eat, but gets into trouble 1 or 2 hours after eating. So and then there is some bile coming out. So we think that there is something which is passing the stomach and then getting obstructed. So some kind of a proximal intestinal obstruction, which would not cause distension, is what would be
another medical condition like this is cyclical vomiting, something like a migraine variant.
Yeah.
But you didn't have bilious vomiting and so much weight loss.
Bilious you can have if you just vomit too much. Anybody can have bilious vomiting.
Okay.
Weight loss would be very unusual. And this typical history of stopping to eat anything solid because she knows it's not going to work. She's just eating liquid diet now. So that would not be there in any kind of a medical problem.
Yes.
So this is more pathognomonic of a physical obstruction of some sort.
An organic cause.
Organic obstruction where she has managed to change her life so much, but then now she's just not happy. So there are many causes of upper GI obstruction. So what is a test that you would like in this child? If you say CT scan, what type of a CT scan? That's very important.
With gastrograph in contrast.
Yeah, so I would want a plain CT, then an added IV contrast, and then an added gastrographin. I would want all three.
Yeah.
Because you can have problems with all three. If you just do a plain, you will miss out on a lot. If you just do plain with gastrographin, you will still miss out on a lot. So you need plain with contrast with gastrographin. It has to be in that sequence. So when you're ordering CT scans for problems of GI tract, more often than not, you need a CT scan with IV contrast with oral contrast. So what happened was we saw on the CT scan that she had a very dilated stomach, a very dilated duodenum here. Is my pointer seen?
Yes.
Yeah. So very, very dilated duodenum here. Now this is the second part of duodenum, which is supposed to pass between the superior mesenteric and aorta to the other side. That's the C of the duodenum. If you remember, the duodenum is C-shaped. So coming down, it has to pass between this aorta and the superior mesenteric, and there's absolutely no space here. So if you look at the diagram here below, normally this superior mesenteric comes at quite an acute angle, quite an obtuse angle, which was lost and it had become very acute. So in normal people, this angle is around 35 to 40 degrees. In her, on this measurement, it is around 12 degrees. So there is no space for the duodenum to come out between this, and this happens typically in children who have big growth spurts. So she has become tall very significantly, and for some reason, they lose the fat in that area, and the superior mesenteric comes very closer to the aorta at this age typically, and then the duodenum gets squashed. So this is an area where we don't like to operate. So what we do is we take the first loop of jejunum, attach it to duodenum, and do a duodenojejunectomy. So that's what she had as a laparoscopic duodenojejunectomy. So this is a superior mesenteric artery syndrome, and she had a duodenojejunectomy for the same. So quick summary of my cases. So what is significant vomiting? When the vomiting is non-bilious, it is significant if it is large quantity, it is projectile, if it is frequent, almost every feed, and if there are life-threatening incidents. If it is bilious, do consider sepsis and preterm babies, but apart from that, any large quantity or frequent bilious vomiting is usually surgical cause. Pylorexinosis, I think we already discussed. I think I've already mentioned everything here. I think I've discussed gastroesophageal reflux also. Malrotation and duodenal pathology or upper GI pathology, the vomiting is usually intermittent. It may be both small, large quantity. It may have component of both bilious and non-bilious. It usually occurs at least half an hour in small babies and an hour in bigger children after feeds. Distension is usually only epigastric if it is there, unless it's a volvulus in a small baby and the whole abdomen gets distended. If you do an X-ray, typically you'll see scanty distal gas in a neonate particularly. And upper GI contrast study is the gold standard. Do not use barium. How do you do in your own setup if you have a neonate and you're suspecting this? Just purchase a vial of contrast and keep it. It's always useful to put it in different orifices and do studies. So you can take a small amount of contrast, 2 to 5 ml, put it down in RT, and take films at 1 to 5 and 10 minutes. That's all. What we're trying to do is not take it too delayed so that you don't miss that sea of duodenum. Because that sea of duodenum is the crux for us whenever we're talking about malrotation or any such pathologies. This is for neonates. If you cannot shift the baby out very easily to a center to do this study. What I've not covered is rarer condition like achalasia. I've operated a few cases of achalasia also, where the vomiting is usually immediately after feeds. It is within seconds or minutes. There is some significant dysphagia. There will be usually weight loss. If there is no weight loss, to call that as achalasia or even to operate on that is usually not the correct thing. So achalasia usually will have weight loss. And here, usually it occurs in older children. You can use barium also. And what Madam had said, peritoneal intestinal bands, adhesions, mesopolic hernias, they will usually have colicky pain and they will usually have some distension. That's all. Thank you very much.
Thank you so much, Kant. You gave us an array of cases of vomiting, non-bilious, bilious, and GERD and malrotation. And of course, this lovely superior mesenteric artery syndrome. So thank you. They were really unusual and very eye-opening for us. And after a heavy meal, yeah, in an afternoon like this, vomiting is not really very appetizing, but you made it very interesting and something which we will always remember, because I remember your case which you had presented of
6-year-old it was,
yeah,
many years back.
Many years back. So that was in the pre-COVID area. So thank you very much for all your interesting cases. And
thank you for this honor. Thank you very much.
Yeah. With this, we now go on to our medical cases, and Dr. Aditi is going to present that. Dr. Lalit Verma, however, I'm very sorry to say, will not be able to attend, but Kant is here. Kant can also comment on it. And I have requested Dr. Ankit Gupta to join us. I don't know whether he has. Also, Dr. Nitu Mundhra had a very bad meconium aspiration case for which she had to be present. Now, I don't know if she has joined, but Aditi, I will also request her to.
I joined. Nitu madam has joined.
Okay,
Nitu. Just now. I was seeing listening to the all talks while doing the.
You were there for Kant's talk, huh?
Yeah, half of it, madam, half of it.
That
case which sir presented now, that bilious vomiting and malrotation.
Yeah.
I have to say that the baby is following to us, and they were twin babies, and the second baby who got treated is at par with the first one and gaining weight very nicely. Now he's around 4 kg. It's all good. Wow. On breastfeeds. That is the most important.
Okay, superb. So there's an overlap of care over here. So that's wonderful. So with that, we go to Aditi. Aditi, please start your presentation.
Thank you, ma'am. Good afternoon to all, and thank you for having me here. Just a moment.
Joshi sir, madam, and Jayashree madam is joined through YouTube link.
Okay, great. So after a lot of vomiting, there is more vomiting coming up. Sorry about that.
No, that's okay.
Mine is it's a short case. It's a 15-year-old male child who came with multiple episodes of vomiting fresh blood, and it was not accompanied with nausea. And it was sudden in onset. He came to us within an hour or so, and he had already had 2 episodes of large amounts of vomiting at home. And during stabilization, the quick history that we got was there was a history of tonsillectomy, which was done 10 days ago in South Mumbai. and there was no bleeding from any other side. The child was very stable. He had come walking, and we were yet to review the papers, the drug history and everything, but this happened very suddenly. The child was absolutely fine before that. And he had gone to a GP who had correctly given them pantoprazole, domperidone, and etamisulate to for the bleeding. On examination, he was vitally stable. He was oriented. There was no pallor. There was no jaundice. And the abdomen was soft. There was no organomegaly also. Oral cavity was full of fresh blood. So we couldn't really see the tonsillar bed to see if there is continued bleeding. And by this time, like one of the differentials was post tonsillectomy bleeding, and the other was a GI bleeding. So we started our management. Okay, so we started IV fluids. We sent investigations, the routine investigations, the CBC, INR, APDT, liver function tests, renal function tests, and we sent a blood group cross match because he had lost a large amount of blood. And we started him on injection pantoprazole. So because he was around 50 kgs, we gave him 40 mg of pantoprazole injection and 4 mg of ondansetron. And we gave vitamin K 10 mg, tranexamic acid for the hemostasis. We contacted the ENT surgeon who suggested that you give dilute H2O2 gargles, it will stop. And because infection is a common cause, we also gave him monoseth. And now we had his papers, and we found a very interesting and actually alarming drug history that he was taking etoricoxib and diclofenac 2 to 3 times a day with antibiotics. And we did not, we found tablet rabiprazole as well once a day, but he was taking adult doses 2 to 3 times a day, which was quite a heavy dose. So now we are pretty sure that this is a upper GI bleed. So we sent our investigations, came back. The platelets were normal. The total count was normal. INR was normal. Only thing, the hemoglobin had dropped by around 2.5 gram%. And the liver and renal function tests were within normal limits. So we realized that we are probably dealing with an NSAID-induced bleeding. And thankfully, the child was very stable. And even though he had 2 episodes at home, after coming to us at around 6 p.m., he had 2 to 3 more episodes. And at night, we realized we have to transfer this child. We cannot keep him. So we planned a transfer. And we kept him NBM, we gave him FFP. And because he had already lost almost 1.5 liters and HB had dropped, we still gave him a packed cell transfusion, and we transferred him. So the father was an employee of the railways, so he was interested in taking him to Jagjeevan Ram Hospital, where the child went at emergency endoscopy, and they found a gastric ulcer. And he was treated for the same. He was discharged on proton pump inhibitors and sucralfate. And he's been taking that treatment, and he's vitally stable. He's not had any complications, thankfully. So just to see some causes of upper GI bleed in the adolescent age group. So we have esophagitis. We have a peptic ulcer disease, which is NSAID induced, like in our patient. You have H. pylori infections. Again, this is more of adult causes, but we have to keep these in mind. We have esophageal varices, which is a common and important cause. That's why we were looking for the spleen and any history of jaundice, but there was nothing. There was no history of persistent retching or nausea followed by vomiting for a Mallory-Weiss tear. And usually this bleeding is not like copious amounts of fresh blood. It is usually a blood-tinged vomitus. For a cancer or stomach or esophagus, there was no weight loss. There were no chronic symptoms. This just happened very, very suddenly. And again, gastric erosions, NSAID induced. Then this. So we went, after we finished, after the transfer, we went and we read the standard guidelines from IAP. And there is a lot of text here, but it's just basically we have done pretty much everything over here, except a few things. they have mentioned chest X-ray and abdominal X-ray for foreign bodies, and we did not do a venous blood gas at that time. And we had a talk with the gastroenterologist at Jagjeevan Ram. So he had whatever he had advised, like we had followed pretty much everything that he advised. On history, we did not ask for history of corrosive ingestion or any button battery ingestion, but we found a very obvious history, so we jumped to that. Then management wise, so one interesting thing that I found here was this: avoid IV fluids if the child is not in shock, because if the child has underlying esophageal varices, this can dislodge the clots and cause more bleeding. So this was one thing that we could have done. And they spoke about proton pump inhibitor infusion. The dose that we gave was a very regular dose. We should have realized that in GI bleeding, you need a much higher dose and an infusion rather than just a bolus dose. Octreotide infusion we would have considered if the child had remained with us, but we transferred him immediately. And one more thing that we could have done very easily is insert an NG tube and keep it free, keep it open, so that we know about ongoing losses. And that would have given very clearly told us that this is not post tonsillectomy bleed, it's a GI bleed. So this is just further endoscopy for banding or sclerotherapy for varices, adrenaline for ulcer, any embolization if needed. And if it's a variceal bleeding, then octreotide infusion and balloon tamponade. That would be based on the endoscopy findings. And so this I've already mentioned. What else we could have done? And so we saw the standard treatment guidelines, and they have mentioned pantoprazole doses for more than 40 kg should be 80 mg stat dose, and then 8 mg per hour infusion. And these are the doses for younger children. And you can give it for around 72 hours. And octreotide for variceal bleed. We have seen a lot of these cases as a resident in Sion Hospital. So they used to come with a large spleen, and we used to plan them for scopy and start octreotide. And then we would tell the parents, your child has EHPVO. So this was some of the management that we did, and what else we could have done. And just because the child presented as a post tonsillectomy bleed, let's quickly have a look at that as well. So within 24 hours is a primary bleed. The most common cause of it is slippage of ligature. Beyond that, it is called a secondary bleed, and most common cause of that is infection. So they have mentioned correctly that in addition to your hemostatic management and stabilizing the child, you should give antibiotics and discuss with the ENT. And if needed, you may need to have a surgical management for the same. So that was my first case.
Just let me comment, Aditi. Excellent. Yeah. You have ramified this case, and you have also included my favorite thing, that is standard treatment guidelines.
Thank you, ma'am.
I'm a big fan of standard treatment guidelines because someone has taken great pains in this.
Yes, ma'am.
Prepare them, and
yes,
said that the higher dose of proton pump inhibitors. So important, because most of us do use NSAIDs, and these days with so many NSAIDs now available, especially for simple fever, people giving mefenamic acid.
Yes, ma'am.
So much of ibugesic and ibuprofen being used that it really sends shivers down my back to think what must be happening to the stomach of these children.
Yeah.
Doses are not really well titrated, and some family physicians are not aware of pediatric doses. And like you said that so much of rifoxicab was given, as well as
yes, ma'am.
Diclofenac was given. So these are such high doses. Yeah, Kant has put on his video, so perhaps he wants to say something about this case. Yeah,
because I think you brought out a very important point about giving NSAIDs to these children. Even for surface surgeries, I don't give more than 2-3 days. I don't prescribe it only. So no child is supposed to take for more than 2-3 days, even after surgery. Any superficial, simple surgeries. Only for very deep, major surgeries we give. That also we will give IV paracetamol and almost no NSAIDs. If we have to really give something more, we'll cover it with a morphine analog rather than NSAIDs. So I think your point is very important, that these NSAIDs should not be abused in children.
And also we miss a very important, renal damage. So diclofenac, mefenamic acid can cause so much renal damage. So, and even paracetamol in higher doses are known to cause hepatic damage. So we walk a very fine line between, therapeutic doses and drug overdose. So thank you for bringing out that point. And also this post-tonsillectomy bleed, you made a wonderful flow chart. So
Thank you, ma'am.
much for that, Aditi. Yeah, we
Thank
can
you.
go to the next case. Yeah.
Okay, ma'am. So my next case is an interesting case of neonatal encephalopathy. Unlike sir, I had just have a lot of text on my slides. I'm sorry about that. But we have a full-term child, and he was in the nursing home, and we were called because the child had icterus on day of life 1. So we do our regular history taking, and we found that there was a blood group set up. The child was B positive, mother had O positive blood group. And the child had icterus till the legs, but he was an active child. He was feeding well. And there was nothing peculiar about him. He was doing very well. So we admitted him and we started on IV fluids. We started on double surface phototherapy and we continued the feeds. So when we asked for a detailed maternal history, we got that the first pregnancy was a 11-year-old healthy female child. Then the mother had an MTP at 2 months, 8 years ago. And the third child, 2 years ago, was born as a full-term 3 kg child, but he died on day of life 2 due to convulsions. And the fourth pregnancy was our patient. So what happened after we started him on IV fluids, we continued the feeds, we started on phototherapy, but around 12 to 18 hours after that, the child became very lethargic. He became tachypnic and he started crying in a very peculiar and shrill manner. He became very jittery and he developed hypertonia and the jaundice was worsening and he stopped passing urine. He had 1 ml urine output in nearly 6 hours. So that was very, very less. And then afterwards, he also had 1 episode of generalized convulsion. So now we realized that we are not just dealing with a ABO incompatibility jaundice, we are dealing with something more sinister over here. So we sent investigations. We started the child on oxygen. We did the sugars were normal. That is our first instinct whenever we find that a child has become lethargic. So sugars were normal, but the bilirubin had increased to 13.7. Now, for a hemolytic disease, he never had significant anemia. The HB was always above 15 grams. The platelets were normal, the total count was normal, and the CRP was negative. So we probably don't have a sepsis over here. Then we got in touch with Nitu ma'am, and we transferred the child to Wokhart Hospital for deteriorating condition. And there he was lethargic and comatose. So a metabolic screen was done, a detailed metabolic screen. It revealed a very high ammonia and the child had respiratory acidosis. So he was intubated and IV antibiotics were given. Inotropes were given because now the child had started going into shock. And a peritoneal dialysis was done because he had next to almost nil urine output. After 24 hours of peritoneal dialysis, the ammonia dropped slightly. And we counseled the parents about the child was actually related to one of our staff members. And we counseled the parents that the prognosis does not look good because they had had one neonatal death previously. They knew that this could happen again. We asked them, we tried to transfer the child to a higher center also for financial reasons, but then they wanted to stop all treatment, but the child passed away quite soon. On day 4 of life, the child passed away. And we told them, we talked to the parents about how this could be an inborn error of metabolism. And if they want to plan more children, we should definitely do genetic testing, because this has happened before. So they decided to not have more children. They have a 11-year-old daughter who is healthy and well. So this was the course of the child. And so again, we went back to our reading, and we went back to this flowchart from Nelson, the 21st edition, which is the latest edition. So when do we suspect IEM? There are a lot of pointers, but basically if we have a child who is not feeding well, who is vomiting, and he's lethargic, and the sensorium is not great, even after, and glucose is normal, calcium is normal, B6 is normal, then we should think of commonest cause sepsis always, horses before zebras. But if the septic screen is negative, we are sure that this is probably not sepsis. We don't have anything on the ultrasound brain. Then we think of a metabolic disorder. And one thing we could have done was obtain plasma ammonia and blood gas. That would have given us a lot of clues. Then if the ammonia was high, or normal, we go do a blood gas anyway. If we have acidosis, we calculate the anion gap. If we have a high anion gap acidosis, we think of organic acidemias. If we have a normal blood gas or an alkalotic blood gas, we should think of urea cycle defects. And if we have a normal anion gap metabolic acidosis, we should think of galactosemia or other amino acidopathies. But it is very important that we at least reach till this level, ammonia and venous blood gas, because that will tell us that this is something more than just sepsis or hypoglycemia. And so this very, very long flowchart, but very important flowchart, because it gives you exactly what to ask and what to look for. So family history, which we had in our patient. Then we had a perinatal history in sepsis-like presentation in a neonatal period in the previous child. Then short stature, failure to thrive would probably come later. In CNS, yes, the child definitely had an affected CNS. He had seizures, he had encephalopathy. Then respiratory system, he had become tachypnic. Cardiovascular, the heart rate had never gone up significantly. We didn't do an echo or anything like that. Now these are important things, like eyes, what to look for. You should look for cataracts, corneal opacities, and cherry red spot. And GI, diarrhea and vomiting in a child. So metabolic disorders, like Chokhani sir used to always tell us, they come like a tsunami. The child has 2 episodes of diarrhea and he comes gasping to you, or he has 2 episodes of vomiting and he comes with pH of 6.9. So you should know that this 2 episodes of diarrhea and absolutely dehydrated child, you should not think of just diarrhea. You should always keep metabolic disorders at the back of your mind. And of course, skin and hair changes and any peculiar odors that we may find. And apart from this, we look at lab findings that should prompt a metabolic workup. Hyperammonemia, very important, and venous blood gas, which could have told us so much. So lactates are usually included in blood gas on request. So high lactates can also be found in sepsis. So we have to make an informed decision. And hypoglycemia can be a common presentation along with liver dysfunction. So inborn errors of metabolism is a huge domain. Even the approach to IEM chapter in Nelson is also extremely long with lots of tables. So I have not gone in detail because ma'am is also there with us to shed some light and talk about this in a much better way. I would just like to share something that Ambekar sir had mentioned long ago during one of the Thursday clinics, that how do you counsel a parent whose child might have an IEM? And so he always mentioned that why do we know this on day 2 or 3 of life? So we know scientifically it is because the child is exposed to feeding, and that is how his enzymatic deficiencies become manifest. So he used to say that while telling them, you can tell that children are like boxes of pencils. till you sharpen the pencil, you will not know what is inside. You will not know whether the lead is broken or it's a wrong color. So the child has to be exposed to milk and feeds till we will know what is exactly wrong with him. So this was my second case, and this has been managed at Wockhardt Hospital by Nitu ma'am. So she would also like to tell us about this patient and about metabolic inborn errors of metabolism. Thank you
so much, Aditi. You presented it so beautifully and such lovely slides and
Thank you, ma'am.
flow charts. So, and your messages from Dr. Chokhani and Dr. Amdekar are very well taken. So,
thank you, ma'am.
They are our teachers as well. So that's something that's very encouraging. And I'd request Nitu to speak about this case.
Thank you, madam. This baby came to at around like 3 days of life. I've just take from there. So at first look at the baby, it was like something is wrong with the baby. As you said, the baby was encephalopathic, and the time when the baby was in ambulance, he through 2 episodes of convulsions also, which we managed initially, and the ammonia like was sky high, like 1960 was the ammonia level. So which was there for maybe another maybe previous 24 or 48 hours. And it is said that if the ammonia levels are more than 1,000 or even 3 to 4 hours, they fires your brain. So the baby was encephalopathic, the baby was convulsing, the baby was completely lethargic, and the baby which initially was hyperventilating now has gone into apnea. So the baby's ABG at admission was severe respiratory acidosis. And this thing we have to take in mind, because something like organic acidomia, so there will be a metabolic acidosis, urea cycle defect, so there will be alkalosis, but it is not always the case. You have to look at the clinical picture also. So starting with that, I'll go through the, and this baby actually, they wanted a DAMA and they expired at they just went out of Wockhardt and expired in ambulance, which was, though we were able to send one test of the baby, which was GCMS, the report of which I'll share with you at the end, because it was completely different than what we were expecting. So IM is always mystery till you solve it. So should I share my slides now?
Yeah, till then, let me introduce Dr. Nitu Mundhra. Dr. Nitu Mundhra is a neonatologist, intensivist at Wockhardt Hospital, Mira Road, and very enthusiastic, and she's part of our Palghar group, and we are very happy to have a super specialist like her amongst us.
Is my screen visible, madam?
No, no.
Not yet?
No.
No. I see. Is it now? I think.
No.
Share screen. Okay, I'll go.
You have to go to share screen. Have you opened your presentation earlier? Yeah.
But it's starting from end.
We saw it. We can see.
Just give me 2 minutes. I'll go from the first slide. Okay. So I thank Palghar Academy of Pediatrics for providing me this opportunity to present in front of you. So the case is already, we have discussed the case. We could not actually completely investigate the case because the parents were like very decided that they don't want further investigation. So now what is important, see, my mentor used to say, every case teaches you something and you have to learn that lesson from this case. So what we have learned from this case, which I will summarize through my few slides quickly. Why to think about IM? Why not to take on the hum pediatrician okay IM ke bare mein kyun soche? Why not we have clinical geneticists who can do all the brainstorming and do, because we might lose the bus. We might miss the bus because, as I said, in this case, the baby's ammonia was high for a long time. And even if the baby would have survived, he would have required a liver transplant. And the ultimate result as a neurological outcome would have not been that great, because I said ammonia for longer, but for even a 4 or 5 hours, high ammonias can deteriorate the brain function. So most important is to suspect an IM and refer properly. There are more than 700, 800 IMs, so we cannot go in detail of everyone. No one can remember them, but we should have a syndromic approach to them. I will try to summarize and simplify IM as much as possible. And special note in sampling, because sampling is the most important thing which we will require to diagnose it. This term was coined by a physician, Garrod. Though individually it is rare, but if we see the incidence is 1 in 800, and if we see the Indian studies done in 2017 and 11, the incidence found to be around 1 in 600 to 1 in 560. There are presently more than 700 conditions described, and if you see just the neonatologists concerned more about the NICU, 5 to 15% of all sick newborns in NICU is expected to have some IM. And if as a pediatrician also, if you see the causes of mental retardation, 6% cases of mental retardation are related to IM. And if I say my personal experience, living apart the KEM experience, where we have a lot of babies, in Bukhard itself in 7 months, I have seen 5 cases of IM, which is very, I would say it is not very rare. So we have to know about it. So this data I just quoted, these were the retrospective studies done. They have done TMS and collected the data. They have done GCMS and collected the data. And you see the cases diagnosed were 323 out of 23,000 GCMS collected. Not all the sampling, only from GCMS they could diagnose this much. And from TMS, it was a government maternity hospital in Andhra Pradesh, and they have diagnosed around 47 cases which were out of range. So it is not that rare to avoid. Simple mechanism is we eat A, it has to be converted into B and ultimately to C, but I don't have this enzyme E or its cofactor, and finally it can lead to a toxic metabolite which is D or its metabolite D1. Just a minute. So if we go for as I said, it is very long, like a lot of diseases. So we go for a broad category classification, which is nowadays more simplified version of IM classification. Either it will be a small molecular type, energy deficient type, or storage disorders. What the Aditi was describing, you have to see eye, liver and all. It is related to all storage disorders. In neonatology period, what comes more commonly is small molecular type or the energy deficiency side. Will you just excuse me for a second, madam? Just a second. Hello, please call after Smita. So now coming to how this small molecular lysosomal or energy metabolism type presents. So onset in neonatal period is either small molecular type or an energy metabolism type. And later on, it may present in the early infancy or neonatal period is lysosomal storage disorders, which may present even in the late childhood also. And these are totally different presentations. We are today currently focusing on the small molecular and energy metabolism type, which will be presenting on the early neonatal period. There would be a symptom-free interval as she described the box of pencils in the small molecular type. But if the patient is having energy metabolism type of disorder, there won't be any symptom-free interval and baby might be symptomatic right from the birth. The accumulations in the lysosomal storage, we know, is intracellular, whereas in small molecular type is extracellular. There is no influence of diet for lysosomal storage, but there is influence when it is small molecular type or may not be in an energy metabolism type. This is very important. If there is a period of stability followed by instability, we think about small molecular type. If there is a progressive episodic deterioration, we more think about the energy metabolism type. And if it is slowly progressive, indolent course, then we think about the lysosomal storage. Example is organic acidemia for small molecular or urea cycle defect, and for energy metabolism type, it is the respiratory chain disorder. Now coming to when should we suspect it can be an IM. The most important thing is the first glance. Looking at the baby, if you feel there is something wrong, please believe your instinct and go ahead and do some further investigation rather than the routine. Then you go again, dig the history, like we have digged in this case, patient, antenatal history, kya tha, what was the, why was the sibling death, how it was died, and the other thing. And third is you go and get all the clinical symptoms and categorize them in whether it is a hepatic, cardiac, metabolic, or the CNS side. Now, once we have some suspicion, we go for like this kind. When we suspect there is a poor feeding history, like this baby had started at 28 hours of life. The baby was lethargic. He had seizure on day 3 of life. He was not vomiting, but baby had distress follow. Which you can say it can be a sepsis, it can be anything else also. But for this, we have investigated because we were thinking about something else. There was obviously a history of sibling death. It was not falsely attributed to sepsis in this case and was rightly referred for a further investigation. So in short, if you feel like Professor Kadyum ki kuch to gadbad hai daya, go and get the investigation. They may have an unexpected and mysterious deterioration and normal routine investigation, not responding to symptomatic treatment. Like they had bilirubin, we have given DSPT, we have given fluids, we have given everything. Despite that, there was a liver failure in babies, bilirubin was not coming down. Baby was progressively deteriorating. And then we think about some few clinical features. Now, where you do the reappraisal and think about whether the baby is fitting into some broad category. So number one, you have to think about this presenting complaint is either intoxication type, which is in small molecular, or it is energy deficient type, which is, we said ki energy deficient is like because of respiratory chain defect or the pyridoxine deficiency. In intoxication type, which we have already discussed, there will be a symptom-free interval. Then baby will go into poor feeding, then go into coma, then go into neurovegetative step. Peculiarly, this baby will have abnormal tones. They may have axial hypotonia with limb hypertonia, tremors, myoclonic jerk, and any peculiar order which is not normal, like sweaty feet disorder, tomcat urine, or fishy disorders, maple syrup order. Then this is not a normal order of newborn, and we go further. In energy deficient type, it may be less evocative. There would not be any dramatic course like normal, then going to vegetative like this. But there can be severe generalized hypotonia. There can be progressive neurological deterioration. There could be deformations, malformations. And finally, if you go with this babies, you can find further investigation, which we'll discuss, lactate and metabolic acidosis. Some babies might have, I had this case last week itself, the patient name was Sabah. He admitted to us with only intractable seizures, nothing else. Myoclonic jerk, typical hypertonia of both the limbs, hypotonia of the upper limb. No ABGs is normal, CBCs are normal, everything is normal. And we were suspecting some IM cause of intractable seizure. Again, as our bad luck, the parents was not agreeing for the further thus, we have collected the samples and the TMS which are awaited. We'll see what happens to this baby. But if it is a seizure as a inaugural symptom, it might not get detected in simple GCMS or TMS. You might need further investigation. And what are the diseases which we suspect when you have only intractable seizures and not anything else? Is pyridoxine dependent seizures. So the best diagnosis when you give pyridoxine, the baby will improve. Folinic acid dependent seizures, same. If it is an NKH, you have to do a CSF and see the ratios. If it is more than 0.8, we say it is non-ketotic hyperglycemia, and baby will have intractable seizure. Sulfite oxidase deficiency and paroxysmal disorders. These are the things which present from predominantly with seizure disorder only. Other patient, like this patient, also have seizures like in maple syrup urine disorder or urea cycle defect or organic acidomias. But this will have along with some other features also. It is prudent to go undergo an EEG when you're, ma'am, am I running short of time? Then I will go fast. No?
You can carry on, Nitu.
Okay. If it is going too much, then also I will shorten it up. It is okay. Then there is, if the baby is having severe metabolic hypotonia. Hypotonia is common in hypothyroidism, Down syndromes, perinatal asphyxia, but metabolic hypotonia will be severe. The baby will like a logwood. And this happens in few disorders like respiratory chain disorders. We know hypotonia because respiratory chain is important for muscle function. There will be no muscle function, there will have no tone. In hereditary hyperlactic acidemia, same, it is the energy deficient time and baby will have severe hypotonia. Along with this CNS disorder like NKH, sulfite oxidase, peroxisomal disorder, they will have hypotonia. In urea cycle defect also there is a prominent finding of hypotonia present. We will go for associated finding of encephalopathy, increased lactate and ammonia, and then we can diagnose. Rarely a Pompe disease can present in neonatal period and you will find a heart which is not normal, dilated cardiomyopathy. Another kind of symptoms which we can see is hepatomegaly, hypoglycemia or seizures. And we have, if this three act together, we think of either glycogenosis type 1 or 3 which present in the neonatal period, or glyconeogenesis defect, or severe hyperinsulinism. Baby will have severe hypoglycemia, not responding, refractory, requiring high GR, requiring all kind of drugs and not responding. Then you must think of these disorders also. If the patient is presenting with cholestatic jaundice and failure to thrive, these are the disorders which should be kept in the mind. Again, I'm saying it is not mandatory to memorize and learn all this, but have this syndromic approach. CNS है, encephalopathic है, seizure है, hepatic है, liver है, or it is associated with cardiac disorder or hematological disorder, and then you go specifically for those disorders. If it is a liver failure with raised enzymes, low protein, raised INR, having high bilirubin, then you think about this result which we did in. So much of disturbance, I know, sorry, I'm in office hours in OPD. And lastly, if it is a Ray-like illness, it is a urea cycle defect or fatty acid oxidation defect. Now, if the baby has advanced renal failure, these babies are very bad prognosis if we don't treat on time. And the diagnoses are like hyperammonemia, hyperlactasemia, hypoglycemia. This all we learn when we learn cholestatic disorder or bile acid defects. Lastly, cardiac presentation, dilated cardiomyopathy for Pompe disorder, fatty acid oxidation defect or respiratory chain disorder. And if there is an effusion and arrhythmia, don't forget about the low chain fatty acid disorders. Or lastly, IM with this dysmorphism. If the baby looks like Downs, but it is not Downs, think about Zellweger. If this baby has long philtrum, epicanthal fold, antiverted flared Allen-Izai, think about the PDH deficiency. If the baby has macrocephaly, facial dysformism, glutaric aciduria type 2 presents early. If the baby has syndactyly, genital abnormality, we might be thinking about Smith-Lemli-Opus syndrome. If it is inverted nipple, lipodystrophy, CDH, or if it is Hurler type phenotype, LSD or lysosomal disorders can be think of. And every time a neonatologist is presented with a case, he or she always looks at the mother, always. And the baby is having help, mother is having help-like syndrome, or mother is having mirror disorder. It can be a PKU, phenylketonuria aciduria. Now coming to this 5 basic syndrome which we already described when we bundle them. Neurologic deterioration, intoxication type. What we described in intoxication is symptom-free interval, then progressive disorders and related to feeds. Abnormal movement, hypertonia. Think about maple syrup disorder. If it is neurologic deterioration, intoxication type, dehydration, organic acidemia. If it is neurological deterioration, energy deficient type, cardiac and liver involvement, fatty acid oxidation defect. Neurologic deterioration, energetic deficiency, and hypotonia. Then we think about the multiple carboxylate deficiency. So we just define the syndromes, combine them, and come to a diagnosis before sending out the other tests, because it is not shooting in the blind. We should know what we are dealing with. Neurologic deterioration, intoxication type, moderate hepatocellular disorders, hypotonia, seizures, like in this patient, our first diagnosis was urea cycle defect with a sky-high ammonia of around 2000. Neurologic deterioration, seizures as a main symptom, myoclonic jerk, severe hypotonia, it is NKH, non-ketotic hyperglycemia. And if it is just a hepatic presentation, you should think about the respiratory chain disorder also. So these slides are very important. Again, I said, just you have to bundleize the approach and think about a diagnosis. And once you think, yes, there's some disorder which I'm thinking, then ask your Daya to break the door. So break the door means we will go for the investigation. Daya ne darwaza toda and we will go. 5 investigations are more important to start with. This is, as she described, one is number 1, glucose. Number 2, ABG. Number 3, lactate. Number 4, ammonia. Number 5 is ketone bodies. So it is mnemonic is GALAK, GALAK. You should always do this test as when you are suspecting IM disorder, and this will hint us about the further disorder and further test. Other basic investigation which we need to do is a renal function test, which may be deranged in the urea cycle defect, liver function test, which may be deranged in RCD, right? Respiratory chain disorder, coagulation profile same, CPK in disorder with fatty acid oxidation defect, complete blood count, because we know the pancytopenias are common in organic acidemia, right? Methylmalonic acidemia or propionic acidemia. Uric acid and urine non-glucose reducing substance are present in the glucose metabolism defect. So these are the other basic investigation which we send so that it might help in the diagnosis. And this is, I would say, the most important slide of the whole presentation. If this you take as a take-home message, this is a justification for the presentation. So I have said that we will do GALAK, GALAK, glucose, ABG, lactate, ammonia, and ketone. And this is how we interpret this test. Sending a test, interpreting is most important. Glucose is normal. There is an acidosis. सब कुछ abnormal है, glucose normal. Acidosis है, lactate बढ़ा हुआ है, ammonia बढ़ा हुआ है, ketone बढ़ा हुआ है. This is organic acidemia. Then you have respiratory alkalosis. Again, I said, keep in mind the clinical presentation of the baby. Like this patient doesn't have respiratory alkalosis, presented with respiratory acidosis, in fact, because he was beyond the stage of just hyperventilation. He was in the stage of apnea. So there is a respiratory alkalosis, glucose is normal, lactate is normal, but there is high ammonias which are more than 600 to 800. Ketones are normal. You think about the urea cycle defect. Glucose is low. There is either normal ABG or an acidosis. Lactate is normal. Ammonia is normal, but ketones are low. So non-ketotic hypoglycemia with either acidosis or non-acidosis. You think about the fatty acid oxidation defect. Last is two more. So if it is low glucose, normal, or mild acidosis with very, very high lactate, you are dealing with something in the pyruvate dehydrogenase deficiency or pyruvate carboxylase deficiency. And lastly, if you have normal or small acidosis with low glucose, normal lactate, normal ammonia, but high ketone, and we know this is maple syrup urine disorder. So this is the few common disorder which can be diagnosed on basis of just the few simple tests which are available everywhere, and we can do them. Now, once we have pinpointed the diagnosis, we are dealing with this kind of syndrome, we will go for the further test, and in which the second line would be HPLC, where amino acid assay will be done and amino acid ureas, organic acid urea can be diagnosed, and a GCMS, where unique organic acid assays and some of the urea cycle defect can be diagnosed. And lastly, the TMS, which we will see the acyl carnitine profile, where amino acid ureas and some fatty acid oxidation defect can be diagnosed. Just remember, few diseases are very difficult to diagnose with this normal test. Are like, one is biotinidase deficiency. But in biotinidase deficiency, we will have one peculiar finding. Anyone want to answer?
Hair changes will be very visible.
Number two,
mentation. There won't be any encephalopathy.
Ma'am, they could. And third thing, which is more important, is there will be a skin rashes, which are very different rashes in the biotinidase deficiency, which will not it's extensive rashes and not responding to any treatment. So if that kind of scenario is there, thankfully there is some sign, then we can send direct enzyme assay for this test, because it will not get diagnosed in any of the other tests we have described till now. If it is a case of intractable seizure with myoclonic jerk, we know we have to send a CSF, and always preserve a sample of CSF. Remember, because LP is nothing we are going to do every day. It is not a blood test. Whenever you send CSF for metabolic screening, always preserve 2 samples for yourself for further test if you are dealing with any seizure disorder. And MRI, in cases of encephalopathy, we tend to order an MRI, and there are some cases where it is helpful. Like in maple syrup disease, there will be white matter disorder. In cases of organic acidemia like MMA or PA, there will be basal ganglion disorders. So MRI also will help you to find out what we are dealing with. And once you know what we are dealing with, you can go for the specific test. And in the era of now genetic test, we can go for direct molecular diagnosis, either a clinical exome sequencing or whole genome sequencing or microarray. And then you always involve a genetist with you, and you counsel the parent before sending the test. Get a genetic counseling, why we are sending the test, what is the turnout time, because the turnout time is not a 2-3 days, it is a long time. It may take even 2 months to come. And what is this test is going to help this baby or the next baby? And we might, after all the tests, we might miss 30% of these orders. So which is very important too, because they are sending a test which is 50,000 or 60,000, and we might have negative outcome. One very important line is the result of IM test is as good as the sample sent, which is very important. If you have not sent your sample properly, your test result will not be good. So these are the practical point which we know. When we are sending ammonia, we have to be, it is an arterial sample, free flowing, transported quickly on ice, plasma to be separated within 15 minutes, because as the time passes, ammonia result will not be reliable. If you are sending an ABG, obviously it will send on an ice and it has to be processed immediately. If you are sending a lactate, similarly, it has to be processed. For ammonia, it is very sensitive. If you don't send properly, you use a tourniquet, you don't use ice, you shake it vigorously, it is processed after 4 hours, the results are not reliable at all. And you will miss the thing. If you are sending a GCMS, at least 10 ml of urine should be sent. It should be refrigerated and no preservative to be added. We have a case of non-immune hydrops just admitted to an ICU. We sent a placenta as such during the time of delivery itself, and we make sure, maybe said that the placenta should be sent in the saline, not formalin fixed. So these are the important things which have to kept in mind. Otherwise, the whole sample is lost. If you formalin fix it, you won't be able to do any genetic test on that. Always collect a EDTA sample for molecular test at the admission itself. You are suspecting IM for further workup. So this would be the practical things to diagnose. Otherwise, we will miss few important things. Sometimes, unfortunately, baby may not make it and may pass, like 10 to 30% of the cases, babies survive in IM cases. Then what sample we preserve for further thing? You can go for a DNA banking. And what the sample we need is an heparinized 5 ml deep frozen plasma. You may have a DBS test, TMS, like a TMS normally sent. Always, again, TMS is very important test. Dry blood sample to be collected. It should be a single spot. There should not be a multiple layering of the spots. There should not be vacuolation. So those 5 circles should be filled properly. If the circle is not completely filled, it's okay, but there should not be overlapping layers of the blood on it. Otherwise, the test will not be reliable. And if the patient is already expired, we won't get the sample again. So this is very important. If keep a EDTA deep frozen sample, urine, keep a CSF, if possible, bile also can be collected. And like I said, skin biopsy. Today only we have done a skin biopsy of that NIH patient because we know the baby is very bad and we need a DNA banking. So we have sent a skin biopsy for DNA banking of that patient. Just a ½ inch of the skin, take a elliptical section, take it just with some muscular tissue, and do not freeze it, do not put formalin, just normal saline samples, and you send it for the banking. Liver biopsy is possible, if possible. Deep frozen and muscle biopsy is possible when you are suspecting a storage disorder. These are important to send. So this is very important to send sample properly because the workup will take time. And once the whole phenotype is there, then we will be able to diagnose the case. So this was most importantly how to approach an IM. This next 2 slides, only 2 slides, madam, are on simple principle of the treatment. Till the time we have diagnosed, how do we approach the treatment? Number 1, obviously we'll stop feeds initially when we are suspecting IM. But remember, it should not be for an X number of days the feeds are stopped, you have to restart feed, because if the catabolism will start, there will be again the increment of the metabolites. So not more than 24 to 48 hours restriction of protein is recommended. After 48 hours, you start with low protein, like 1 gram per kg, and then you build up as the baby's condition allows. Start with the high GR. They recommend to start with 10 straightforward. For that, if you need long line, put a long line. Obviously, you will need a long line if the fluids are restricted or the high GR is there initial days. Do not reduce GR if the baby become hyperglycemic. Instead, you use an insulin. If you are suspecting any sepsis, start on antibiotic. Once your cultures are negative, you de-escalate and stop it. Give high calories, at least 100 kilocalories per kg. But we know what is the normal calories required for a newborn is around, anyone to answer, 65 to 74. But this cases, we give more. And then only one cases where we avoid a high GR is PDH cases, where we know because this is not going to get metabolized into the energy because we have an defect at the energy cycle itself. And if you started high GR and patient is having worsening lactic acidosis, use IV lipid instead of GIR and rethink about the PDH. You will high lactate here. So that will again give you a clue. You can start carnitine, which is most efficient when given as IV in organic acidemia or fatty acid oxidation defect. There are several coenzymes. We say it is an IM cocktail, like you start B6, B12, this in B1, thiamine. So B1, B6, B12, you can start when you don't know what you are dealing with. And then further, when you have this, the reports has come, you can pinpoint what defect it is and what coenzyme I would require. And most importantly, what we started with this case was because the ammonia was 1960. So we know it is not going to come down with any of these figures, and we started directly on PD. Peritoneal dialysis was started, which again, the PD fluid has to be optimized as per the condition. So since this baby had severe acidosis, we did a bicarbonate PD. So if it is high lactate, bicarbonate, so we have to see what we are dealing with, and the PD fluid need to be optimized accordingly. But start PD, don't afraid of starting PD because it is going to help. We need to reduce the toxic metabolite early. If it is severe acidosis refractory, again PT is recommended. And ultimate aim with what I said was to prevent the irreversible brain damage. This is very most important because this is going to have long-term impact on this baby's life. This is what in short is the treatment for IM. We know the substrate is there. There is an enzyme or cofactor deficiency and product is not been produced. And it is going to another pathway producing a metabolite which is toxic. So what we will do first thing is removal of the toxin. This is the first foremost thing, for which we might start a PD, we will give the fluid, we will see the baby is given carnitine in some disorder or sodium benzoate in urea cycle defect. The IV preparations are not available in India. We do some indigenous preparation, 50 to 150 milligram per kg we start with. Then second step you will do there is decrease this substrate. So we stop the feeds, and then once the diagnosis is done, we start with the special diet, which are available for a lot of disorder nowadays. Special formulas are available, though costly, but they are available. Finally, you give some cofactor replacement to try to reverse this biochemical pathway here. And finally, if it is some disorder which need ultimate diagnosis, then you may have enzyme replacement or transplantation. And nowadays the molecular genetics has advanced and gene therapy is on the way. It is available for few disorder, but it is on the way for the other disorders. Not yet very widely available, but this is alternative. With this, I think I end my slides with this take-home message. High index of suspicion is important. Early diagnosis is important in preventing the sequelae of IM. And if you are suspecting, don't at least hesitate to send this 5 initial investigation, and not sending the investigation, sending them properly and interpreting them properly is very important. This is what I would say. That's all. These are the references.
Yeah, thank you so much, Nitu. And we're so happy you're close by so that anything difficult we can send to you.
Thank you, ma'am.
Then we send it to you. And for us, it is to remember that any jaundice that does not respond to treatment, any intractable seizures, patient going into encephalopathy, previous sibling death, and something smelling not exactly right. And I think Aditi has asked what was the GCMS. You were going to tell us in the end.
Yes, I was going to tell us this. So though I had a clinical suspicion of urea cycle defect, which is actually which was the diagnosis at the time when we started, because the baby had this apneas, convulsions, hypotonia, which we have just described, and this high level of ammonias. There was a period of normalcy, and then the baby progressively deteriorated. So it was a small molecular type. We could not do TMS or further genetic test, but the GCMS report has come as urine showed the elevated level of lactic acid, pyruvic acid, ketones, succinate and fumarate. So it was not very specific. It can be present. It can be there in organic acidemias. It can be present in the mitochondriopathies. So we had to do further tests, which could not do. So they asked us to do some other tests and to rule out the mitochondrial disorders. So this was what was sent to us. So it was 3 diagnoses where at the end of this test was an organic acidemia, mitochondrial disorders, third was urea cycle defect. So keep your thinking, we were not thinking about the mitochondrial disorder with this presentation, which was not the presentation of mitochondrial disorder, but the report has come like this. But I still think it was a urea cycle disorder because it was not presenting as an energy deficient type, which is the characteristic of the mitochondrial disorder. So it was a small molecular, we can say it was a small molecular type, probably a urea cycle defect, to rule out organic acidemia. This would be my diagnosis based on the results I have.
Thank you so much, Nitu. And for us who are practicing neonatology or pediatrics, just keeping a high index of suspicion in any case that we find is intractable or with previous neonatal or child deaths, then it's time for us to think of something metabolic. With that, thank you for your extensive presentation, Nitu. And if you can share your PDF file with us, upload it on our Facebook site, and we can have it for future reference. And that is just so that we start suspecting early. And also what she said about collecting sample and DNA banking is very important. I think it's pretty cheap to do DNA banking, and it's only when you want to
3 to 5,000 is just, and then instead of like rushing on the diagnosis, ye base de, wo base de, we can do DNA banking, take the whole phenotype, let the all reports come up. TMS aayega 7 days mein, GCMS aayega 3 days mein, and then we can go for the further test. So that would be good.
Yeah. So that is what, and for DNA banking, all we have to do is collect 4 ml of blood in EDTA and keep it, and later we can do this test. So, and you have to keep it just in the normal fridge, and it can be kept for a very long time. If you want to send it to the lab for storage, I think they charge 1,500 and it can be kept for a lifetime. And anytime the parents want it for investigation, they can do it. So that was what I was told. But please do think of metabolic disorders and do collect the correct samples, and do send for all those tests, and do refer to the correct person at the right time. So thank you very much, Nitu, and yeah, hope to see you on many of our webinars.
Oh, madam, it's my pleasure to be there.
And thank you, Aditi.
Sorry for delay today. I had to rush in an ICU to OT.
Yeah, please. And thank you, Aditi. And I'd like to mention that these 2 patients were worked up in Joshi Children's Hospital by young Aditi and our senior pediatricians, Dr. Archana Joshi, Hemant Joshi, who have joined us from, they are in Germany. No, they are in UK. They are in UK and they have joined us on YouTube. So I can't see them, but I'm sure they're listening to every word that you're saying, Aditi. And thank you on behalf of Palghar Academy. And with this, we go to the last presentation of today. Dr. Anuradha Palwankar is a senior practicing pediatrician at Virar. She's also attached to the Tulinj Municipal Hospital at Nalasopara East. And today she's going to present standard treatment guidelines on hyperactivity disorder. So go ahead, Anuradha. Thank you.
Good evening, everyone. Today I'm presenting standard treatment guidelines for attention deficit hyperactivity disorder. Can you see my screen?
Yes.
Yes, we can. And it's full screen too.
Okay. So, attention deficit hyperactivity disorder, nowadays we are seeing it very frequently. So, introduction to ADHD. Attention deficit hyperactivity disorder is a chronic condition with genetic and neurobiological basis, which manifests in early childhood with symptoms of hyperactivity, impulsivity, and or inattention affecting the emotional, academic, and social functioning of the child. The prevalence of ADHD in a community-based sample in India in school children was around 11%. So there are two subtypes. One is hyperactivity, impulsivity. Second is inattention, and third is both. We see both hyperactivity, impulsivity, and inattention together. So characteristics of symptoms: age of onset of hyperactivity, impulsivity is observed by 4 years of age, and we observe inattention by 8 to 9 years of age, and peak is hyperactivity peaks by 7 to 8 years and then declines, and impulsivity persists throughout adulthood, and inattention peaks and persists throughout adulthood. So first we'll see the symptoms of hyperactivity, impulsivity. There is excessive fidgetiness. Excessive fidgetiness is creating a lot of fuss. Has difficulty staying seated where required, school and work. Be on the go in a constant motion. Run around or climb in situations where it is not appropriate. Difficulty in playing, doing an activity quietly, excessive talking, blurt out answers interrupting the questioner, difficulty in waiting for turn, and interrupt conversations, games, and activities. In inattention, we see fail to pay close attention to details, make careless mistakes in schoolwork, difficulty in focusing on task or play, appears not to listen even when spoken to directly, fails to follow through on instructions, finish homework, and chorus, trouble organizing tasks, activities, and belongings, avoids or dislikes tasks that require focused mental efforts such as homework, loses items needed for tasks or activities such as toys, school assignment, pencils, and books, easily gets distracted, forgetfulness in daily activities like homework and chorus. And the characteristic of symptoms is should occur often. These symptoms should occur often, be present in more than one setting, that is school and home, persist for at least 6 months, be present before the age of 12 years. Impair function in academic, school, or occupational activities. There will be excessive for the developmental level of the child, then have negatively impacted academic, social, and or occupational functioning. In patients aged less than 17 years, more than or equal to 6 symptoms are necessary. And in those aged more than or equal to 17 years, more than or equal to 5 symptoms are necessary. Other causes of core symptoms are ruled out, like psychiatric, physical, and neurological illnesses. So there are clinical subtypes, combined type, that is hyperactivity, impulsivity plus inattention. It is 60 to 70% cases. It is more common. Predominantly inattention is 25 to 30% cases, and predominantly hyperactive impulsive is 8 to 10%. So it is needed to minimize underdiagnosis and overdiagnosis of ADHD, which include confirmed core symptoms of hyperactivity, impulsivity, and inattention. So look for presence of symptoms, persistence of symptoms, pervasiveness, that is how much symptoms they are getting, whether at home also, whether at school also. Then functional complications by thorough history, general examination, and neurological examination. Then parent and teacher rating scale, that is Vanderbilt and Kanner scale. These are scales which are used for ADHD patients, where multiple questions are asked regarding symptoms, and they grade it like from 0 to 3. So there are no symptoms, then grading is 0. Then occasional symptoms is 1. Fewer symptoms, like very often symptoms are there, then the grading is 2, and very often is 3, and accordingly they make the scale, and then they decide the severity of the disease. Then fulfill DSM-5 criteria. DSM-5 criteria is diagnostic and statistical manual of mental disorders. DSM-5 criteria are the main symptoms of ADHD. Then we have to exclude the differential diagnosis. Developmental variation. DDs are developmental variations. Differential diagnosis of ADHD is normal variation, low and high IQ, neurological conditions like autism, spectrum disorders, learning disability, seizure disorder, neurodevelopmental syndromes like Fragile X and fetal alcohol, communication disorders, then other emotional disorders like depression, anxiety, mood, oppositional defiant disorder, that is kids are disobedient. Then conduct disorder, they have antisocial behavior, bipolar and obsessive compulsive disorder, psychosocial problems like child abuse, neglect, or bullying, medical conditions like hearing, vision impairment, sleep disorder, anemia, substance abuse, and thyroid disorders. These are few differential diagnoses. Then identify comorbid conditions. Oppositional defiant disorders is present in 50% kids, like they are disobedient. Conduct disorder, they have antisocial behavior, and it is associated like 25% in 25% patient it is associated with ADHD. Learning disability is 7%, and autism spectrum disorder, anxiety, depression, tics, and obsessive compulsive disorder. These are some disorders which are associated comorbid conditions in ADHD. So modalities of management. In management of ADHD, first is behavioral interventions. So the first line of treatment for preschool children, that is below 6 years, we have to go with behavioral therapy. In behavioral therapy, we have to talk to the parents, and we have to do positive reinforcement, and we have to communicate with the child in positive way, and we have to discipline them, like time management, or we have to give some small tasks, and accordingly we have to give behavioral therapy to ADHD children below 6 years. Above 6 years, medication is advised. With or without behavioral interventions are the first line therapy for school age children more than or equal to 6 years, and adolescents who meet the diagnostic criteria of ADHD. Then educational interventions, and combination of all of the above. So in behavioral treatment, we have to do positive reinforcements like providing rewards or privileges according to the good behavior after completing household duties and assignments, and child can watch TV or play on the computer. Then second is timeout. Remove any factors that could reinforce problem or unwanted behavior. Like after displaying rude behavior, example hitting the brother, or the child has to sit in the corner of the room for a period of time, that is 5 minutes or so. Then response cost. Withdrawing rewards or privileges after unwanted or problem behavior. If homework was not completed, the child loses free time privileges. And token economy, combination of positive reinforcement and response cost. Child earns stars for completed assignments and loses stars for untoward behavior. Example, getting out of his or her seat. Age appropriate screen time can be permitted. Below 2 years, there is 0 screen time. 2 to 5 years, 1 hour screen time. And 5 to 17 years, not more than 2 hours screen time.
Not more than 2 hours.
Smita, please mute yourself. Pallavi, please mute. Yeah, thank you.
So, next is medical management. So general principles of psychopharmacological management of ADHD. An accurate diagnosis of ADHD should be documented before starting medication. A child below 6 to 7 years of age should not be started on medications unless the child is extremely accident prone, and that needs to be after careful evaluation by an expert in the field. Before starting medication, the family should be educated about the purpose and goals of the medication, that they are not curative, but will help to manage symptoms and may be required for many years. Medication should not be forced on any patient. Other management tools such as psychoeducation strategies and behavioral therapy should be instituted along with pharmacological treatment. So treatment should be started with a low dose and increase slowly till the symptoms improve and maximum dose is achieved or toxicity limits dose increase. Then suggested effective behavioral techniques for children with ADHD. Excuse me, one minute, next slide. So these are the drugs which are used for the treatment of ADHD. First is methylphenidate, which is stimulant, and the dosage forms available are 5 milligram, 10 milligram, and 20 milligram tablets. The duration of action is 3 to 5 hours, and start with 5 milligram per day for first day, and then 5 milligram twice a day. And the maximum dose below 25 kg is 35 milligram and above 25 kg is 60 milligram. The other methylphenidate, which is delayed onset, doses available is 5 milligram, 10 milligram, and 20 milligram tablets. Duration of action is a little slower, that is 3 to 8 hours. Dose is 5 milligram per kg twice daily dosing. Increments of 20 milligram per kg every 3 to 7 days. So below 50 kg, 60 milligram, and above 50 kg, it is 100 milligram. Third is methylphenidate, which is available 18 milligram and 36 milligram tablet. Here the duration of action is 12 hours, and initiate with 18 milligram daily once in the morning, Children 6 to 8 years of age, 18 milligram per day, 18 to 50 or 18 to 54 milligram per day. And in adolescents, in adolescents 13 to 17 years of age, 18 milligram per day, and the range is 18 to 72 milligram per day, not to exceed 2 milligram per kg per day. So the maximum dose is children 6 to 12 years, 54 milligram per day, and 13 to 17 years is 72 milligram per day. Next is non-stimulant, which is atomoxetine. Atomoxetine and methylphenidate, these are the drugs. In ADHD children, they are deficient of neurotransmitters like dopamine and norepinephrine. And this methylphenidate and atomoxetine increases the levels of dopamine and norepinephrine. So second drug is atomoxetine, which is available in 10, 18 and 25 milligram. The onset of action is 10 to 12 hours. Start with 0.5 milligram per kg for minimum of 3 days and increase to 1.2 milligram per kg per day after at least 3 days. Maximum dose of atomoxetine is 100 milligram per kg or 1.5 milligram per kg, whichever is lesser. Because methylphenidate, the stimulants causes euphoric effect, and child may become addict to these drugs. So we have to decide the maximum limit of the drugs. So prognosis is persistence of ADHD at the age of 25 years, meeting full criteria of ADHD is approximately 15%. ADHD in partial remission is approximately 65%. Symptoms of inattention persist for more or show slower decline. So we have to they are very hyperactive, so we have to use their energy in activities like sports. We have to involve them in sports so that they can concentrate over there, and we have to teach them time management in adolescent period, so that they can fulfill their daily activities, and they can finish their daily activities or daily homework or chorus. So that way we have to give therapy and plus medications also, but not below 6 years. Above 6 years, medications are indicated. Thank you.
Thank you so much, Anuradha. The importance of knowing ADHD is that there is a comorbidity of conduct disorder as well as substance abuse, and as well as antisocial behavior in later life. And I think there's also a big comorbidity of learning disabilities. So we have to be very vigilant, and especially in the teenagers, this is something that we have to look out for. Thank you for bringing this out all in this presentation. I can see Dr. Alka Jadhav in the audience. Alka, would you like to comment something? Please unmute and say.
Hello.
Yeah, hi.
Hi. Actually, I really received the link from my niece and then I joined. So it's very nice presentation. Though I had already forgotten. So though I attended the last half an hour, but wonderful activity. Next, whenever you're having it next, I'll definitely join now. But it's a beautiful presentation. The attention deficit ADHD has been brought out very well. Actually, quite often we have to insist on that it controls the problem and not cures the problem. That is something which we probably need to insist on the people Otherwise, it will have doctor shopping effect. So we really have to tell them about titrating the dose, keeping the follow-up with behavior checklist, and keeping about how much is the reduction in the hyperactivity, and assessing mainly the performances with the help of school teacher. This will really help, I think. This will go a long way. So really, thank you.
Any role of diet in ADHD?
Actually, they definitely say that we have the diet to a certain extent. Some people definitely feel that ketogenic diet will also help to a certain extent. And we reduce the gluten, less gluten diet, they definitely, and the soya-based diet. So
sugar intake?
Sugar intake moderately can be permitted, but excessive sugars have to be avoided. So this is something which is a less gluten diet. Moderate sugar intake can be, because anyway we don't add much sugar to the children's feed nowadays with newer guidelines. So this has to be definitely.
Yeah, Dr. Alka Jadhav is a retired professor and was head of Department of Pediatrics in Sion Hospital. She is a pediatric gastroenterologist. For all those who don't know,
oh my God.
Palghar Academy are very familiar with her. Thank you, Alka, for joining in.
Oh, thank you for my, I will definitely be a part of this group henceforth. So really, thank you so much. Yeah, definitely.
There's one very good story I always like to share about ADHD. Michael Phelps, the 23-time Olympic gold winner in swimming, had ADHD when he was in nursery. His nursery teacher had told him and his mother, this boy is good for nothing. He cannot sit in one place. But he took to, like Anuradha said, he took to sport, and he used to practice for 8 hours of swimming every day. Now you can imagine he comes from Australia, and to swim for 8 hours continuously, what kind of activity? So this boy went on to become, and by the age of 25, he had won 23 gold medals in swimming in Olympics. So that's how you can put your activity to or hyperactivity to good use. Thank you very much, Anuradha, for that. With this, we come to an end. I'd like to thank all the presenters today. We had epidemiology, Dr. Kishore Chavan, Dr. Smita Chavan. Then we had Dr. Kant presenting. We had young Aditi presenting 2 cases. We had Dr. Nitu Mundhra, and we had Dr. Anuradha Palwankar presenting the standard treatment guidelines on ADHD. What a kaleidoscope of this. We have Dr. Chitra Kulkarni from Raigad. Dr. Chitra, would you like to say something? Would you like to come in and comment? I think Dr. Chitra cannot unmute herself. So with that, I'd like to also thank Dr. Vaibhavi Barot, our secretary, Dr. Anuradha Palwankar, our treasurer. Both of them have worked very hard to get this webinar going. I thank all those who have joined us today. I hope you have learned something. And I hope you like. We are going to meet again in a physical CME on the 11th of Jan. More of this on the group when Dr. Vaibhavi can confirm. It's going to be on epilepsy with Dr. Pradnya Gadgil and her neurosurgery colleague. Vaibhavi, you'd like to say something on that now, or you'll put it up later in the group?
Ma'am, I will put it up later because it is not yet fully decided.
Confirm. Okay, so we'll be putting that is going to be our next CME, and also going to meet on the 4th Wednesday of next month. And Alka, you are part of our group, so please look out for the message.
You can add Alka madam to our group.
Yes, definitely.
Part of the group. Yeah. I will add her if she's not. And with that, I thank everyone. I thank Pallavi Dharma, Mrs. Pallavi Dharmadikari, who has been our digital expert. There were a little glitches because it's the first time we are working together, but I'm sure this is going to get eased out with time. And you can, if you have missed part of today's talk, then you can catch it up on YouTube on Palghar Academy of Pediatric YouTube channel. And with that, we sign off today. Wishing everyone in advance a very happy new year. I hope brings in lot of peace, prosperity, no COVID. I hope we can eliminate measles by the end of 2023. And all of us stay healthy, happy, and prosperous. And we keep learning and keep meeting on this platform. With that, wishing everyone a happy 2023 from Palghar Academy of Pediatrics. And bye. Bye for now.
Thank you, madam.
Thank you. Bye.
Thank you, everyone.
Thank you, everyone. Thank you. Pallavi, Anuradha, don't sign off, please. Anuradha and Vaibhavi, don't sign off.